Okay, so it's my great pleasure to be able to introduce an incredible innovator and one of the acknowledged experts in the field of neuromodulation through the use of neurosurgery, a number of different techniques, whether it's MR-guided focused ultrasound or whether it is deep brain stimulation. We are all incredibly fortunate to be able to have Dr. Nir Lipsman, who is also a professor in the Department of Surgery, joining us today. He's an incredible speaker. I have to say that I'm always learning something new whenever I hear him speak. And again, you may be aware if you look at his first slide as well as the biography I had posted for you, he's not only a clinician, but he's also a researcher, and he has both his MD as well as his PhD. And I will welcome him on behalf of the class because I know you're all muted right now. So thank you so much for joining us today.
Thank you so much, Professor Ju. Always a pleasure to give this talk. This is obviously new for me to do this this session over Zoom, but always happy to. And thank you so much for the warm invitation and everybody out there. Usually, I'm used to seeing everybody's faces, smiling faces in the crowd. So I'm assuming everybody's smiling at home and is tuned in. But so as Dr. Ju sort of alluded to, my name is Nir Lipsman, and I am a neurosurgeon at Sunnybrook Health Sciences Center. And I went to UofT as an undergrad in Queens for medical school. And throughout all of that training and my neurosurgery training at UofT, throughout all my training, I was really interested in brain function and brain dysfunction in particular, and what could go wrong and to what we can attribute brain function and dysfunction. So I was always interested in the brain from a functional perspective, and to that end, in trying to determine what we can do as clinicians to try to improve that in some way. So it led me down the road of pursuing a field known as functional neurosurgery, which is a branch of neurosurgery that deals essentially with diseases or conditions where there may not necessarily be anything obvious on a CT or an MRI scan that you can point to and say that is what's wrong with the patient. But there's something profoundly wrong with the patient. So it could be on a molecular level, it can be on a cellular level, or what have you. But the idea is that there are conditions where you can have significant effects, but you can't obviously point to dysfunction structurally in the brain. So a lot of that is going to be the topic of what I'll discuss in the next hour and a half approximately. A few just housekeeping things. It will last about an hour and a half. I'll pause about halfway in between, for a break. If needed. And then the other thing is I am on call. I'm covering neurosurgery at Sunnybrook today. So once in a while there may be my phone may go off and I may have to look at it just to make sure that there's no emergencies happening that I need to deal with. So hopefully that won't happen. But if you see me leering on my phone, that's what I'm doing. So, okay, let's proceed. So this is Sunnybrook, for those of you who don't know. It's a huge hospital in Midtown Toronto, and essentially it does many different things. We do many different things here, but one of the things we really do very strongly in it is the clinical neurosciences. So it's a major brain trauma center, it's a major stroke center, cognitive neurology and dementia, in psychiatry. So I'm privileged to work amongst a group of really amazing investigators and collaborators, and what we're trying to do is develop new treatments for all these different kinds of conditions. So much of the work that we're doing takes place in this building. So to begin with, really what we're talking about, as I said, brain dysfunction, we need to talk about brain function first. And then, you're confronted with the first question, which is, how do we know what different parts of the brain actually do? We ascribe to the brain, but how do we do that? How have we done that in the history of neurosciences? Well, generally speaking, and this is an oversimplification, but generally speaking, there are a few ways. One is lesions. So looking at brain damage, either caused by a structural problem like a brain tumor or a stroke or something like that. And then when you have a loss of function, you can ascribe a function of that part of the brain to function. In the olden days, it was really autopsy. You saw how somebody behaved or misbehaved, and then they passed away, and you looked at their brain, and then again, you can ascribe different functions to different parts of the brain. In the 1930s and 40s, we started the era of brain stimulation. This is awake brain stimulation with patients at the operating room, and we're still doing this today. I'll show you some examples of actively stimulating the brain during an operation and saying, hey, yeah, that part of the brain does X, and this part of the brain does Y. And then we can create a kind of map of what the brain does. And probably the most powerful means is brain imaging. And this was developed in the last probably 40 years. So MRI scanning in the 1980s really came to more frequent use, and CT scan before then in the 70s. And this really allowed us to start to ascribe function to different parts of the brain, specifically the more recent sequences and advances in functional imaging, where in real time, if a patient is engaged in some kind of behavior, you can see what part of the brain is active. So these are really the main ways up until now. So of course, lesions, as you know, this gentleman, is in the lore of neuroscience. Phineas Gage is his name. And as we know, this was one of the first anatomical pathologic links between a traumatic brain injury as a result of a railroad spike in between while he was working on a railroad, resulting in actual change in behavior. And the interesting part is that when his own skull was reconstructed to create this 3D reconstruction of a CT scan, you can see that the spike went through the bottom of the zygoma, which is this bone over here in the cheek, through the bottom part of his brain and out the other side. It was what we call a through and through injury. And when he was injured, he was taken to a local physician, and what they actually were able to do is insert a finger this part through this part of the head and through underneath his cheekbone, and actually touch the fingers in between. So this was a real true through and through injury, and miraculously he survived this. And not only to survive this, he went on to be the subject of many investigations, including behavioral investigations, which noted that before his injury, he was really one of the favorite people that were at his job, very efficient and capable, the favorite sort of best friend of many people that were working there. After his injury, however, this is a quote: "He was fitful, irreverent, indulging in the grossest profanity, manifesting little deference to his fellows, impatient of restraint." So in sum, and this is the famous quote, of course, Gage was no longer Gage. And then the issue came up: why was that the case? Why was it that this trauma led to differences in behavior? Let me give you another example. So this is a situation of a 40-year-old male, otherwise healthy, had a normal marriage and family life, and during the span of a year began to acquire a large collection of child pornography, actively concealed this illicit, illegal behavior from his family and friends. Ultimately, the police got involved, and he was ordered out of his home and prescribed essentially a chemical castration, so medroxyprogesterone, to control his hormonal urges. Now, he also happened to complain at the time of headaches. So throughout the whole process, progressing to balance problems, and an MRI scan was ordered, which identified this lesion right, mostly centered on the right prefrontal cortex and the right orbital frontal cortex, which is over here, displacing these basically upwards and posteriorly. So the idea was that he underwent surgery for this, and this led to a complete resolution of his impulses, successfully completed a rehab program, and made an uneventful recovery. So the behaviors went away. But then he began to collect the illicit material again, and the scan showed that the tumor had come back. So unbeknownst to him, obviously, the tumor was coming back, the behavior came back, and once more, he began to engage in this kind of behavior. So that link between that disinhibition, that lack of judgment, that lack of ability to appreciate the consequences of one's awareness were happening outside of his conscious awareness. So it was happening as a result of a structural lesion in that area. So in both of those cases, the OFC, the orbital frontal cortex, and the PFC, the prefrontal cortex, these were lesions there, and they led to profound changes in behavior, personality, ambitions, thoughts, and interactions. And the question then becomes, how can damage to a single brain structure in the brain lead to a wholesale change in one's entire way of being? So their motor function was intact, sensory function was intact, everything was intact other than their profound judgment in the area. So this is where we start talking about the fact that much of our human behavior and thought is governed by brain circuits, neural circuits, that damage or dysfunction and key nodes in those circuits can lead to dysfunction of the entire circuit. So much like you have an electrical circuit that exists where key nodes are all connected to each other, as discussed, much like you can have key nodes that are connected to each other, you can have dysfunction at any one of those nodes at any one of those parts, and that will lead to wholesale circuit-wide dysfunction. So it's not necessarily the case that every one of those nodes needs to be dysfunctional. Only one is sufficient to be dysfunction, and it could be a chemical, structural, or other kinds of dysfunction, and you can get dysfunction of the entire circuit, leading to aberrant kind of behavior. So these are the principles I sort of wanted to, structure as a sort of take-home message by the end of the talk, and this sort of guides a lot of our discussion. And the first is that the idea that brain circuits govern voluntary and involuntary human behavior, that brain circuits are made up of those nodes that can be connected mono or polysynaptically, so there are structural links between them. The dysfunction in critical nodes or these pathways leads to circuit-wide dysfunction, and that manifests as many brain-based disorders, which we'll go through in a moment. And that all of our treatments in neuroscience, whether in neurosurgery or psychiatry or neurology, are aimed at restoring function in those circuits in some way, okay? And that their implications there are significant for how we understand the diseases, how it develops, how it's maintained, ultimately how it's treated and experienced by the patient. So this idea that different regions of the brain can be structurally connected is not new. So James Papes and Paul MacLean were neurophysiologists that worked together. And what they did is they identified what's called a Papes circuit and the expanded limbic circuit, as Paul MacLean identified. These are the structures in our brain, usually basal, usually midline, that are connected either mono or polysynaptically, and that govern a lot of our emotional life. But we know that structural connection is one thing, but different regions can also be functionally connected. So activity in one region will influence activity in another region. So it's not only the fact that they're structurally, but they're functionally connected with biochemical links between them. And there are many circuits in the brain, but what we know is they take roughly the same skeleton framework, with cortical structures projecting to basal ganglia or deep structures, projecting to the thalamus, and ultimately back to the cortex in a kind of loop, so in a kind of circuit. And these are called the cortical, striatal, thalamic, cortical loops. And that exactly which cortical structure projects to which part of the basal ganglia and thalamus, etc., will ultimately determine the nature of that circuit and what that circuit ultimately does. So this is an example. This is work done by Alexander and DeLong, who are again are neurologists and neurophysiology partners back in the 1980s. And the exact details of this are not important, but the message remains the same, that whether you're looking at motor structures, oculomotor, so that's eye movements, or higher cognitive processes like mood and decision-making and things like that, you're gonna have that same cortical, striatal, thalamic, cortical loop. And for each one of these functions, these are just categories, and you're gonna have different structures within them. And you can imagine that dysfunction within any of these nodes will lead to propagated dysfunction throughout the entire circuit. So every voluntary and involuntary activity that we do is governed by a different kind of circuit. The one that's best studied is the motor circuit, and it's the one that connects the primary motor cortex with the striatum, which is the motor part of our basal ganglia. And then it goes back to the cortex through the VL nucleus of the thalamus. Okay, so this circuit essentially governs all voluntary human actions, as well as some involuntary ones like posture, walking, the muscular contractions that you make when you're walking or when you're shifting around. And then the key neurotransmitter here is dopamine, which is produced by the substantia nigra. So this is a classic condition where that motor circuit is basically dysfunctional, and this is Parkinson's disease. So it's the paradigmatic motor circuit condition. So again, what do I mean by that? I mean that there are large circuits in the brain that are distributed broadly in the brain, but dysfunction is propagated throughout that circuit by focal pathology. So in this case, loss of dopaminergic neurons in the substantia nigra will lead to system-wide, brain-wide dysfunction, resulting in manifesting in a broad range of neurologic and sometimes even psychiatric conditions. So in this case, it's somebody who has slowing down of movement, postural instability, a tremor. But of course, Parkinson's is much more than that. It can affect sleep, sexual function, appetite, and a whole broad range of conditions. Currently, the way we treat Parkinson's is aimed at treating the motor symptoms exclusively and quality of life improvement. And the mainstay is to replace dopamine or to mimic its action in some way. But there's downsides to that. Not only do dopamine medications have side effects, but over time they're less and less effective, because you can imagine the dopaminergic neurons will continue to degenerate over time. Dopamine itself does not restore life to those dopamine neurons and doesn't restore them and doesn't protect them in any way. So we're really talking about symptomatic treatment, and that over time becomes less effective. But for patients who don't tolerate medications or who've reached the limits maybe of what medical treatments can offer, surgery becomes an option. And this is when neurosurgeons have been involved now for many, many years. These are neurosurgery, neurology partners, Ernst Spiegel and Henry Weisses in the US. They developed what's called a stereotactic frame that allows us to essentially, with precision strike accuracy, target specific areas of the brain to try to restore activity within those nodes in the circuit that aren't functioning properly. And throughout the last 60 or 70 years, different procedures have been developed to try to address every aspect of that motor circuit in Parkinson's to try to help. So this is the frame that Spiegel and Weisses developed. And then what happened over time, you started to see these procedures becoming much more popular. So this is Lars Leksell, who's a Swedish neurosurgeon in the 60s. This is Ron Tasker, who's a Canadian neurosurgeon here at the University of Toronto, performing the same procedure on patients with Parkinson's disease to try to access parts of the brain that we know are not functioning properly in order to restore activity more broadly. So when you look at PD or Parkinson's over time, you can see that over time, what happened was shortly after it was identified, the pathology was looked at and better defined. And then in the 1960s, L-DOPA, which is the dopamine replacement therapy, was introduced into clinical practice. What that led to is a significant decline in surgery being done for Parkinson's, because why do surgery when replacing dopamine can help with the symptoms, can help with the tremor, rigidity, etc., and then became more widely used. But over time, it became very clear that not everyone responded to dopamine replacement. Some patients just did not. Some did respond, but got less benefit over time. And that side effects occurred with dopamine replacement. So interest in surgery began to rise again. And until 1980s, the way that surgery essentially was done is you made a skin incision, holes in the skull, you inserted an electrode into the brain, and you destroyed the parts of the neurons, or you destroyed the neurons in the part of the circuit in Parkinson's that wasn't working in order to restore activity to that circuit. But in the late 80s, surgeons in France, what they started to do is they inserted the electrodes, but they did not burn those neurons. They did not kill them. What they did was they stimulated them to sort of disrupt their activity. And rather than damaging neurons, they just knocked them out, or they disrupted them to restore activity in that circuit. The era of deep brain stimulation was born. So this idea of a pacemaker-like device, and you've all heard of pacemakers, I'm sure, where there's a battery and electrodes that go to the heart to stimulate it. This is a pacemaker device where the electrodes don't go to the heart, they go to the brain. And the idea is that they stimulate that part of the brain that's not functioning properly in order to restore its activity. So how do we know where to put the electrodes then? Where we need to put the electrodes in a part of the circuit where we know that there's dysfunction, and it has to be structurally connected to the entire circuit you're trying to influence. And the way that we determine those targets is ideally targets that are surgically accessible, that are safe, and that there's a robust amount of evidence, whether from imaging or animal models, to support it. So in Parkinson's disease, we insert the electrodes in this part of the brain, in the subthalamic nucleus, or the STN. So this is a structure that is both structurally and functionally connected to the entire circuit, as we've seen. And we know that when we record activity from neurons in that part of the brain, they fire inappropriately. They fire in a kind of bursting type pattern that is bad for the brain, that is not conducive to normal activity. Usually you want random activity, and here you have pathologic bursting type activity that you want to abolish. And putting stimulation in that part of the brain abolishes those symptoms and restores activity in the entire circuit. So you can take a patient that looks like this, with a tremendous slowing of movements. You can see the masked faces, small amplitude of movements, and then patient few months after surgery looks like this, with a real restoration of motor function. So you'll recall that all you're doing here is stimulating a 5 millimeter structure in the brain, something that is less than a centimeter. And you see these profound influences on every aspect of motor function, not only facial expression, but fluidity of movement, the ability to walk without falling, and the ability to turn around without having to take multiple steps. So again, quick stimulate, a small amount of stimulation to a small part of the brain result in profound effects. So currently, as a result of success like that, DBS, deep brain stimulation, is approved for the disease. You know, we won't go into the data to support it, but there is a robust mountain of data to support the clinical efficacy of DBS. And as a result of that, it's being explored in many other kinds of conditions where what we believe the goal should be to disrupt and restore activity in these motor circuits. One of them is dystonia, which is this condition over here. I'll just play this video. It's a bit of an older video, but it demonstrates the point. So this is a condition that affects children predominantly. It's called DYT1 dystonia. It's a genetic form of movement disorders where there's abnormal contraction of musculature beyond the control of the child in this case. So this is a child from Israel, actually, that comes from a family of 7 or 8 siblings, and 5 of them have this condition. Okay, so this is a boy who, up until 2 years before this video was taken, was entirely normal. Okay, had normal motor, sensory, intellectual development, and then he began to develop this movement disorder. So intellectually and cognitively, the patient is entirely intact. He's actually the best student in his class. It's really exclusively a motor circuit condition, where what's wrong is the inability to control activity into that circuit. So deep brain stimulation was proposed, and the part of the brain that was targeted is known as the globus pallidus. And then several months after the procedure, this was him. Okay, this was him able to walk. So again, we are stimulating here a part of the brain that is less than a centimeter. Okay, so a very small part of the brain. You can see profound effects on every aspect of his motor life. And this underscores the fact that a condition as complex as DYT1 dystonia just requires resetting activity in a small part of the brain. You can see the entire circuit being ameliorated, essentially. Now, deep brain stimulation involves an implant that's implanted into the body and a battery that needs to be replaced every 3 to 4 years. So this boy has had his battery replaced now 4 or 5 times in the last 15 years or so. So the success of DBS in those conditions really led to an explosion of interest in DBS for other kinds of conditions. So what we did was, several years ago, we plotted the number of publications per year dealing with DBS, and you can see an exponential rise in interest. So the value of DBS is that it not only regulates activity in these circuits, you can actually probe activity in these circuits. You can record activity, and that's what allows you to really map function and dysfunction onto these circuits. And there's a tremendous interest in the field in using this as a tool. And we are. So exactly which, as you recall, exactly which cortical structure connects to which basal ganglia thalamic circuit will determine the nature of that circuit. That's really one of the dogmas of the field. And you can begin to see how dysfunction in any structure in that loop will lead to different kinds of disorders. And we're particularly interested in the psychiatric conditions, where if you have, for example, amygdala dysfunction or accumbens dysfunction or cingulate dysfunction can lead to anxiety, reward, or mood disorders potentially and respectively. So if you can relate motor circuit dysfunction to dysfunction in a specific motor node, you may be able to link mood disorder dysfunction, for example, to specific nodal dysfunction affecting nodes in that circuit. So mood and anxiety, however, are much more complex than motor disorders. And if you take 10 patients, for example, with Parkinson's disease, they're more or less going to look about the same in terms of their symptoms. Obviously, there's variations. It's a complex disorder, but depression is much more heterogeneous. Anxiety and OCD, obsessive compulsive disorder, are much more heterogeneous. So in some ways, this is a complexity, it's a challenge, but in other ways, it's also an opportunity. Because what that could mean is that the different complexities may be related to different circuits in the brain, and then you may be able to tailor your treatments to those conditions. So here we've mapped out some of the cognitive, some of the limbic, and some of the reward and motivational circuitry involved in these conditions. Let's talk about depression for a moment. So our thinking about depression has really changed in the last several decades, the last several years, I should say. It used to be referred to really as predominantly a chemical deficit in the brain, but we know it's much more complex and much more heterogeneous than that. There are certainly deficit states in depression, where patients experience things like anhedonia or loss of pleasure, depressed mood, less appetite, less concentration, libido, etc. But there are important non-deficit states. Even I would say, what we call in medicine sort of positive symptoms or additive symptoms, things like pain and rumination and suicidal ideation. So depression is not a disease of a single gene, even a brain region or a neurotransmitter system. It's much more complex than that, as you have the interplay of these different circuits. Now, about 10 years ago now, the director of the National Institute of Mental Health, Tom Insel, in this sort of landmark blog post, really set the stage for disorders like depression and other conditions like them, which is that we should stop viewing them as diseases that occur in isolation in the brain and really see these as circuit-based disorders, where in fact, local disruption and local dysfunction can lead to system or network-wide dysfunction. This really got the ball rolling for a lot of circuit-based neurotherapeutics to be developed, which we'll go through in a moment. How do we treat depression these days? Well, it's usually under the guidance, ideally, of a trained psychiatrist. But what we use, and this is another key point here that's important for psychiatric treatments, we use both bottom-up and top-down approaches. So what does that mean? When we talk about bottom-up approaches, we mean that we're targeting really basal, autonomic, vegetative type symptoms of depression. So this is where medical treatments may potentially help, because we're addressing maybe a biochemical imbalance here that is driving some of the dysfunction on an anatomic level. Top-down processes, they tackle the thoughts, they tackle the perceptions and the cognitive distortions that manifest and that perpetuate the depression. And ideally, when you're treating somebody with depression, you're going to tackle both. You're going to tackle both the thoughts and the cognitive distortions and the underlying biochemical issues. And what we know is that that's the best chance we have of treating depression, both top-down and bottom-up approaches. Now, what happens to patients is that about 2/3 of the time, or maybe even a little bit more, 75% of the time, they do get better. And these approaches are helpful. But in about 1/4 of patients, they do not help. And those patients are known as treatment resistant, treatment refractory. And for them, neuromodulation approaches may be effective. Now, what does the brain look like when it's depressed? So this is work that's done by Helen Mayberg, who was a neurologist and psychiatrist at the University of Toronto. And what she wanted to do is look at the activity of the brain while it's depressed. So if you can imagine taking somebody who has depression unmedicated and putting them in a PET scanner, they can detect blood flow. And what she found was that in patients who are depressed, you see increased activity in this region of the brain here in red, known as the subgenual cingulate area 25. Now, when you take patients who are not depressed, so patients who are healthy, and you put them into the same scanner, but you make them sad, you make them depressed. So you read them a sad story, or they think about something sad, that same part of the brain lights up. So this clued them in, the researchers into the fact that maybe this part of the brain is critical for modulating sadness. And as a result, maybe changing activity in that part of the brain, maybe with something like deep brain stimulation, may change the sadness and may change the depression. So why this work was so important was because it allowed us to identify one of those nodes. Just like we access a node in dystonia or in Parkinson's disease, we need a node that we can access in major depression. And that's exactly what that work did. And that's exactly what they did. They did insert electrodes into that part of the brain. And 3 months and 6 months after DBS was on, you saw a reversal of activity in that part of the brain. So it went from being hyperactive when somebody is depressed to even the overshot, to less active, at 3 and 6 months. And this was linked to improvements in their depression. And when you look at scores of patients at a year and at 3 to 6 years after deep brain stimulation, you see significant reductions In average, Hamilton Rating Scale of Depression, HRSD, is the gold standard way of measuring depression, and you see significant reduction. So you'll recall that these are patients enrolled in these studies who are resistant, who are refractory to all available medical treatments. And we see significant responses at 1 year and at 3 to 6 years. Now, there's a lot of enthusiasm, there's a lot of excitement, there's a lot of promise for these technologies. However, these need to be subject to study. And 2 years ago, or 3 years ago now, a study was published in Lancet Psychiatry, which actually found that when you insert the electrodes into the brain and you turn them on, and you have another group that you insert the electrodes into the brain and you don't turn them on, so a blinded study, and you don't tell the patients what you're doing, and you don't tell the assessors or raters what they're doing, what they found was that there was no significant antidepressant difference at 6 months in the study. So the people that had the operation but no stimulation also felt better. No different than those who had the stimulation. Now, a lot of hand wringing has gone into sort of why this was the case, and we think that a lot of it has to do with actually the nuances of where the actual targeting took place. But suffice it to say, many patients did improve even without stimulation. So currently, this is an area of active investigation. It may be a promising therapeutic option, but many questions remain. What is the optimal target in the brain? Who is the optimal patient? How can we predict who does and doesn't respond? Just like we showed in that randomized controlled trial, can we predict over time who does and doesn't respond? And how can we optimize it? So all of this is still ongoing, a burgeoning area of continued interest. Another area we're really interested in is anorexia nervosa. This, for many of us, is sort of a paradigmatic illness, a paradigmatic disorder where, although the physical manifestations of the disease are very obvious, the malnourishment and malnutrition, we believe that it's being driven not so much by the parts of the brain responsible for appetite or metabolic rate or things like that govern eating per se, but it's being driven by the emotional aspects of the disorder. Okay, so here you have a condition where the mortality is very high, 5 to 20%, the highest of all psychiatric conditions. There's very high rates of psychiatric comorbidity. Almost 100% of patients with anorexia nervosa have a comorbid psychiatric condition, including depression or OCD. And 50% of these patients go on to develop a chronic illness. So there's an urgent need to develop treatments here. And neurosurgeons have been involved from the very beginning. The very first reports of surgery for psychiatric conditions occurred in anorexia, with this unfortunate term here, lobotomy, that is no longer obviously used. But in the last 70 years, we've come a very long way. So we've had psychopharmacology develop, a standardized research ethics board, a common language in our field, and as we saw, the development of stereotactic surgery and imaging, which really allowed us to explore whether other things like DBS could potentially be used. So what we did before embarking on the trial is really create a kind of map for the circuits that may be wrong in anorexia. So again, the exact details here are not too important, but suffice it to say that just like with depression, the best chance of success for treating this condition is going to be taking both a top-down and bottom-up approaches. So you're going to want to tackle both the basal vegetative autonomic dysfunction in the condition, while at the same time tackling a lot of the perceptual, emotional, affective, limbic parts of the disorder as well. And what's interesting when you start delving into the literature of anorexia is that you don't see a lot of structures implicated that are involved in appetite or that are involved in basal metabolic rate or things like that. You see a lot of structures light up that are critical for our emotional life, whether it's the PFC, the OFC, the subgenual cingulate, etc. So we use this and we leverage this experience and knowledge and develop a kind of switch model of anorexia, where this could help us explain why some patients with anorexia, for example, have predominantly restricting subtype, some have binge purge subtype, etc. And this alludes to the earlier point I made about depression being much more complicated disease than something like Parkinson's, where you may have multiple circuits that are dysfunctional at the same time. And on the surface of it, that may look like it makes the condition much more complex, but in fact, it may allow you to tailor your treatments to a specific aspect of the disease. So for example, Patients with depression sometimes have predominantly anhedonia or reward circuit dysfunction. So maybe you want to target just the reward circuitry. Patients with Parkinson's disease, some of them may have psychiatric comorbidities, or some of them may have predominantly gait abnormalities. So you may want to tailor a treatment for that specific condition. So that kind of model really appeals to many of us who really want to tailor and personalize the treatments as much as possible. So for anorexia, what we did is we targeted the subgenual cingulate, just like we do for depression. And this is the part of the brain that we targeted. And we published our experience now several years ago, illustrating that, in fact, you can take patients who are treatment resistant, treatment refractory, and you can perform deep brain stimulation safely. And what we detected was an important signal here. So when we followed patients up to 1 year, what we found here in the blue line is the BMI, the body mass index, gradually went up over the course of a year. But what we found was that in parallel with that, the Yale-Brown Obsessive Compulsive Score, which is an anxiety score, and the HAM-D, which is a depression scores, they went down over time. And what we found was that in order to take advantage of the weight gain advantages that we see with DBS, we need to treat mood and anxiety first. And this sort of, to us, underscored how critical it is to treat the mood and limbic aspects of anorexia in concert with the more physical aspects of it. That it may be that the mood and anxiety were the things that are preventing people from taking advantage of treatments. So the other thing that we did is we stimulated patients during the surgery to try and see whether we saw an acute effect in these patients. We did this for a few reasons. One, this is an invaluable opportunity to study in real time what stimulation could be doing to the brain. And two, it helps us to program patients after the surgery. And this is one of those patients and what they reported and experienced.
Is this sensation a pleasant one or an unpleasant?
So this is an example of somebody that had acute brain stimulation during the procedure and experienced what we call sort of a brightening kind of response, where they reported being a little bit more active, with energy being a little bit higher. We don't see this in everybody, but we did see it in this particular patient. Now, we don't think that it's related to ultimate outcome and how these patients do, but it does tell us a little bit about what this part of the brain does. Now, the other thing that we did is we measured PET scans. So we looked at blood flow in the brain, and we did this at 6 months and at 12 months after deep brain stimulation. And what we found was that some areas of the brain resulted in increased activity, which you can see in red, and some in decreased activity, which you can see in blue. Now, why is this important? Well, when I was analyzing and looking at this, I thought it's just absolutely fascinating that stimulation of a very small part of the brain over here in blue resulted in system network-wide effects, even in areas that are very far in anatomic terms from where we were stimulating, indicating that, in fact, we are seeing this network-wide effect. And the other thing that we saw was a decrease in activity in the part of the brain where we were stimulating. So that suggests that locally, it appears that DBS has an inhibitory kind of effect. So DBS is certainly highly effective at controlling symptoms of movement disorders, can be used bilaterally. So that means you can use it on both sides of the brain. It's non-ablative, which means that it doesn't cause permanent damage to the brain. It's a replacement, in fact, of ablative technology. It can be programmed to optimize clinical effect, and you can use it to minimize side effects. So you can imagine that after somebody's implanted, they go see their psychiatrist or the neurologist, and we can go up or down the stimulation. And what we're going to see in the next several years is significant developments on the technical side. So developments in device size, in battery life, on-demand, closed-loop stimulation. All of this is going to sustain strong academic and clinical interest for many years to come. But, DBS is not all peaches and cream. It's not all roses. There are definitely some issues associated with it. The first is that it's extremely expensive. So both in capital and operating costs. So DBS costs approximately $20,000 to $25,000 per implant. So it's extremely resource intensive. Not only that, we're going to need a neurologist and psychiatrist to program. It can only be done in some centers around the world. There's also the risk of surgery and the risk of device or implant complications. These are not trivial either. So these are permanent, lifelong implants, require reprogramming and frequent visits to the hospital. So it's very onerous often for patients. DBS is image guided, but it's not image guided in real time, which means that you have to insert the electrodes, sometimes blindly, guided by targeting before surgery, but nevertheless not in real time. And the fact is, some patients don't want surgery. So even though they may be eligible for surgery, and even though they see the same videos that I just showed you, some patients don't want surgery. So what then becomes the next step? So neuromodulation, which we're talking about, has really evolved. It's evolved from blinded procedures to image guided, from crude to precise, from permanent to reversible. But the main way that we have interacted with the brain for the last 50 or 60 years has always been with electricity. Can other forms of energy be used to change brain activity beyond electricity? And the answer to that is yes. And maybe we'll take a break there, and I'll continue with the second half after a small break. Is that okay, Bill?
Yeah, I think that's fine.
Okay, I just have to answer.
I heard your phone going off quite a bit. So
yeah, so maybe I'll just answer a few pages and I'll resume in 5 minutes.
Sure, I'll just talk to the class for a bit.
Okay.
Okay, awesome. So folks, I hope you're all doing really well. I think that one of the things that I'm going to try to do in the next week and a half is to get a hold of you for maybe a 5-10 minute really quick chat. And it'd be awesome to kind of touch base with you about the course, just in general, like how you're doing. I know some of you had some other questions about presentations, etc., but we're going to leave that till the next class. So if you're not too busy, you can send me an email if I don't get a hold of you first, and we'll try to figure out a time where I can connect with you for about 5 or 10 minutes on Zoom. All right, so I do hope you will take a little bit of a break.
So where I left off was the idea that, everything that you've seen until now, DBS, and even making lesions in the brain, as you saw, the early attempts at influencing circuitry have all been done using electricity. And the question is, electricity is great, but can we use other forms of energy? And the answer, of course, is yes. And the thing that we're really actively looking at is ultrasound. Ultrasound has a very long history in medicine, is used both diagnostically, of course, but also therapeutically. And one of the advantages, among the advantages of ultrasound, is that it's non-destructive, so it doesn't destroy tissue. It passes harmlessly through tissue. We can use it both to visualize and has robust thermal applications, especially if you combine ultrasound from different sources and you target it to specific areas of the brain. So one of the first uses of focused ultrasound was actually identified by John Lynn, who's a neurologist in the 40s. And he made a very prescient statement in this paper, really one of the first uses of the term focused ultrasound in the literature. And the idea that the property of focusability together in conjunction with the special tissue effects suggests that possibility that an optimum combination of wavelength, intensity, and exposure might be found, which would produce a focal destruction in the depths of tissue. So what basically he's saying there, that you may be able to find optimal parameters of wavelength, intensity, and exposure that will allow you to focus ultrasound from different sources onto very discrete spots and make a whole without having to open the head potentially. And one of the first uses of that concept was in, of course, lobotomy. So common theme, as you can see. And I think it's because psychiatry and the trouble with psychiatric conditions and how difficult they are to treat has driven a lot of innovation and a lot of thought in neurosurgery about how to overcome these conditions. And what you can see here is that this ultrasound transducer in a paper published in the 50s was used to generate this lesion over here beneath the level of the cortex without any intervening damage. So this idea that you can focus ultrasound to discrete parts within the brain without damaging overlying brain was very promising. So two advances really in the last several decades led to focused ultrasound to where we are now. The first is coupling ultrasound with MRI, with real-time MRI. And the second is the idea that if you generate a device, if you create a device that you can transmit that ultrasound through the skull, you don't have to remove the skull. So why would you have to remove the skull? Well, the fact is that the bone of the skull is made of bone, obviously, and bone is not a friend to ultrasound. So the bone of the skull will absorb any ultrasound you try to direct through it. And if you are able to transmit ultrasound through the bone, you're going to have a very hard time refocusing that energy onto discrete parts of the brain. So up until the mid-90s, we needed to make a hole in the skull and apply the ultrasound directly onto the brain in order to generate these lesions deep in the brain. But the idea of creating a helmet-like device, which is what we're using today, to focus ultrasound from many different transducers that line this helmet onto discrete parts of the brain, what that allows us to do is overcome that bone problem, because we're able to basically harness the power of over 1,000 different transducers that exist in the lining of this helmet onto discrete parts of the brain. And the principle is very similar to this, to focusing sunlight onto discrete parts of a leaf and causing, for example, it to burn. So multiple intersecting beams of ultrasound can be focused onto targets a millimeter in size, and they can pass individually, harmlessly through the brain, but where they intersect, you get a convergence point and you get increase in energy. So this is sort of a schematic of what this looked like. You have a patient awake with their head inside this helmet, and then they go into the MRI machine. And then you're individually able to steer these ultrasound transducers to discrete spots within the brain. And what you're able to do there is influence that part of the brain. And if it's not functioning properly, you're able to totally destroy it. So there are many different uses of ultrasound in neurosurgery, and it depends exclusively on the type of ultrasound that you use. If it's high frequency ultrasound, you can generate a hole in the brain without opening the head. And we'll see when you would want to do that. If you use low frequency, you're able to open the blood-brain barrier, which is the ability essentially to deliver therapies to the brain that ordinarily can't get in. So when would you want to make a lesion in the brain? Well, for a whole host of different conditions, ranging from movement disorders to brain tumors to psychiatric disease. So using ultrasound in the rest of the body to generate lesions is basically old news. We do this all the time for fibroids, prostate cancer, bone metastases, and other kinds of conditions. But again, its use in the skull, in the brain, has been limited because of the problem, and that has now been overcome. And what we were looking for was an indication where we can make a hole in the brain in a central part of the brain, a millimeter-sized target with a clear behavior that we can follow. And that made essential tremor really the optimal initial application. So what is essential tremor? This is essential tremor. It's a movement disorder that affects about 3% of the population over the age of 40. And essentially, it's a condition that affects the upper extremities predominantly, usually the dominant arm, but can affect any arm or any extremity actually. And it results in significant disability, as you can see. In its most severe forms, patients are really unable to cope. They cannot feed themselves, they cannot dress themselves, they cannot, really do the basic activities of daily living. And the vast majority of these patients can be treated. They can be treated with medical treatments, which are effective in about 2/3 to 3/4 of patients. But about 1/4 to 1/3 of patients are treatment resistant. They cannot tolerate the medications or they just don't work. So in those patients, surgery becomes an option. All surgical approaches to essential tremor are focused on the same part of the brain that's known as the VIM nucleus of the thalamus. So this nucleus of the thalamus is a critical relay structure between the cerebellum and the motor cortex. And we know that the neurons in this part of the brain, they fire inappropriately in essential tremor. And we know this. We know this for several decades. We've known this from operative treatments where we can record activity in this part of the brain. And then no matter how you treat essential tremor, you target this part of the brain. And you can target it currently in 3 ways. You can either do what's procedure known as a radiofrequency thalamotomy, which is burn that part of the brain with an electrode. You can insert deep brain stimulator electrodes to jam the circuitry in this part of the brain and resulting in improvements. Or you can use radiation therapy, so focused radiation therapy to that part of the brain. But the problem is that each one of those has its side effects, whether it's the risk of surgery or hardware, or in the case of radiation therapy, there's a latency to the effect. You may be able to treat the tremor by destroying that part of the brain, but it's going to take several months. So what focused ultrasound does is it's no incisions, no hardware, and the effect is right away. And we did publish this a few years ago as a first in human kind of trial where we showed that we're able to apply focused ultrasound energy for 10 to 20 seconds to the part of the brain that we want to target with the patient in the MRI scanner. And one of the advantages of doing it with focused ultrasound is that you can in real time track the increase in temperature in that part of the brain that you want to target. So this is something that's not possible with any other surgical approach. You get a maximum temperature and then it cools off over time. So this is one of those patients that we treated. This is a gentleman who's in his 60s. He's an architect. He had to retire from his job because of a severe tremor. And as a result of that, began to experience some mood issues, etc. So clearly very disabled by his tremor. As you can see, it affects both sides of his body. He wanted the right side treated, the right arm. And but he did not want to go any open surgery. He did not want a brain implant. He did not want radio frequency, and he did not want radiation. So he became one of the first patients in our trial of focused ultrasound for the application of essential tremor. Here you can see us getting a writing sample immediately before and getting some other tests. So this is him immediately after the treatment. So it takes about 2 hours to do the procedure, and you can see that we treated the right arm. We can only treat one side with this procedure for now. He still has the tremor on the left side. And you can see that his tremor is completely gone. This is now about 5 years old, this video. He continues to have no tremor on the right side. The reason we don't treat both sides is the rate of side effects is too high. The rate of side effects of causing issues for those functions of the brain that require both sides of the brain, like walking and speech, etc., are too high. So we treat one side for this procedure. Here you can see the average dominant arm tremor score, which significantly reduced and remains low at 3 months. And this is what the lesions look like on the MRI scan. So you can see here in the right thalamus, so right and left are flipped on an MRI scan. And you can see that we generated this lesion. And over time, you can see that even by day 7 and day 30, the lesion gets smaller. And by day 90, it's quite small. But nevertheless, the tremor is still gone. Okay, so it may be just the swelling has decreased and results in a lesion. So we went on to publish a randomized controlled trial that definitively established, in our view, the fact that you can use ultrasound as an alternative means to generate a lesion in this part of the brain critical for the motor circuit. So again, going back to the very beginning of the talk, when we're talking about generating one small lesion or influencing one small part of the brain can have profound impacts on the entire circuit. And that's what we're doing with focused ultrasound. The question then becomes, though, related to the circuitry is, can we use ultrasound to manage non-motor circuit conditions? So just like DBS was used initially in Parkinson's and dystonia, and now is being investigated in depression, can we use ultrasound, which has proven to be quite effective in tremor, for other conditions where making the lesion in the brain may be good? And this is where there are 3 procedures in the context of psychiatric conditions that we can use this for. Capsulotomy for obsessive compulsive disorder, cingulotomy for depression. All of these are lesional procedures. The area of the brain that we want to, are you guys able to hear me? I'm getting a signal that I'm on signal is a bit unstable.
It faded out a bit, but I think
Okay.
it should be fine.
Okay, great. Thank you. So the part of the brain that we're influencing, and specifically in mood and anxiety disorder, is this green line over here, and that connects the orbital frontal cortex with the thalamus and vice versa. There are also thalamic projections to the OFC. And it's this green, this is a DTI, diffusion tractography image of the fibers we want to basically intervene in. And when you map, the beautiful thing here, the reason I like this figure so much is because here you can see the original circuit proposed by James Papes in 1937. And when you do modern imaging with DTI, you can see that many of those same structures are lit up with modern imaging. So sort of confirming something that James Papes and Paul MacLean identified back in the 30s, 40s, and 50s. And what we want to intervene in is this fiber over here with connecting the orbital frontal cortex with the thalamus. And that's exactly what we're starting to do in the context of mood and anxiety disorder. So this is a DTI image of those very same tracts. And what we want to do is generate these lesions over here that you can see in white. These holes over here in a part of the brain known as the anterior limb of the internal capsule, in order to disrupt activity, abnormal activity coming from the orbital frontal cortex, which we saw again all the way from the Phineas Gage days, connecting to the thalamus. And we're beginning to see quite favorable results, both in terms of safety and mood and anxiety. So the first experience was published by the Korean group, the Professor Chang, who showed that in fact you can generate these lesions in the brain with focused ultrasound on both sides of the brain. And so far our results are echoing this as well. We recently published our own paper confirming this. In fact, it's safe to do this procedure, and in fact that we can do it effectively. And this is work that Dr. Ben Davidson, who was one of, I just recently found out, one of Professor Drew's first neuroscience students, and he's now a neurosurgery resident and PhD student in my lab. This is something that he is doing. The last thing I want to discuss is this idea of using ultrasound to open the blood-brain barrier. So why is the blood-brain barrier important for us as neurosurgeons and neurologists? And to underscore that, I often show this. This is an autoradiogram of a mouse that was injected with radioactive histamine and that was sacrificed a half an hour later. So the idea is that histamine will stain tissues black everywhere that it touches. And you can see that two areas that are not stained is the brain and the spinal cord. And that's because of the blood-brain barrier. So the blood-brain barrier is sort of invisible to the naked eye barrier that invests the very fine blood vessels of the brain that physically prevents large compounds from getting into the brain. So how does focused ultrasound help overcome the blood-brain barrier that prevents drugs from getting into the brain? Well, this is how it does that. So you can imagine that these red balls over here are a contrast agent that we actually inject patients with. It's microscopic bubbles, they circulate throughout the body. Then they get to the brain, and when they're in the brain, they're exposed to focused ultrasound, and they will oscillate very quickly, 500,000 times a second. And they'll cause a physical pulling apart of the cells making up the blood-brain barrier. So it's a mechanical disruptive force. And that opening of the blood-brain barrier creates a kind of window for these purple compounds, which can be any drug that you want to deliver, to get into the brain. And ordinarily, these purple things cannot get into the brain, but now we provide a kind of window of 6 to 8 hours for whatever is co-circulating to get into the brain. This is what this looks like in a pig model, okay? So this here is contrast. Contrast is something that weighs about 1 kilodalton and ordinarily only goes to parts of the brain where the blood-brain barrier is open. And here we were able to show in this animal model, and has recently been showed in 300 animal models, that you can in fact open the blood-brain barrier safely. Additional work that was done by the group here at Sunnybrook, Kalervo Hinanen is one of the inventors actually of focused ultrasound. What they were able to show in this seminal paper published in 2006 is that they can take mice and they can open the blood-brain barrier and they can deliver Herceptin. So Herceptin is a very large compound. It weighs 150 kilodaltons. The average molecular weight of something that can get across the BBB is 400 daltons. So Herceptin is 2 orders of magnitude larger. And they were able to show that by opening the blood-brain barrier, that can actually enhance the delivery of Herceptin to the brain successfully. So what are the potential applications? Where any condition where the passage of the blood-brain barrier is required or has been an obstacle to novel therapies can potentially now be used with BBB opening and focused ultrasound. We're particularly interested in brain tumors and Alzheimer's disease. And in fact, our focused ultrasound center is now developed multiple platforms to investigate focused ultrasound for a whole host of different conditions. Everything green is something we're using blood-brain barrier opening for. Everything blue is we're investigating lesional applications. So let me talk briefly about Alzheimer's disease. Of course, it's epidemic proportions. In 2013, 16 million caregivers provided 18 billion hours of unpaid care. So it cost the economy untold numbers. And indeed, by 2050, expected to cost over $1 trillion in lost productivity. So there's an urgent need to develop novel therapies for this condition. Now, one of the most promising signs or promising evidence in the last few years has come with this drug known as aducanumab. Aducanumab, as every drug that ends with MAB, is a monoclonal antibody, similar to Herceptin, very large antibody that ordinarily can't get into the brain. And what this study was able to show, and this was published in Nature I think a year or two ago, what they were able to show is that as they went up on the dose of aducanumab, they saw significant improvement in amyloid deposition in the brain. So we know that amyloid is an abnormal protein that develops outside of the neurons in the brain. This is baseline for patients, and this is 1 year after with escalating doses. So you can see that they may be able to clear amyloid. And what they were also able to show that at 1 year, there was a stabilization in one of the measures that are used to measure dementia, the clinical dementia rating scale. And you can see that this blue, at the very highest doses, we saw stabilization of the score at 1 year. So this was very promising, really the first sign that a drug delivered can reduce amyloid and maybe stabilize one of the cognitive measures. But the problem is that the higher you went up with the dose, the more side effects patients had, the more strokes they had, the more they didn't tolerate the medication. So if you could potentially deliver aducanumab in smaller concentrations, you may be able to see the clinical effect without as many of the side effects. So this is something that is currently ongoing. What's also interesting about focused ultrasound, and this is again work that's been done here at Sunnybrook, showed that you may not even need to deliver a therapeutic to the brain to see an effect. So this is work that was done by Isabelle Aubert that showed that opening the blood-brain barrier at the hippocampus in transgenic animal models leads to a reduction in amyloid plaque and improvements in behavior, even in the absence of delivering a therapeutic. So it may be that the body's own endogenous immune system is able to gain access to the brain and help clear some of that amyloid in and of itself. So we leveraged that preclinical data. We created a phase 1 trial where the goal was really to show that we can safely open the blood-brain barrier in patients with Alzheimer's disease. So this is one of those patients with amyloid deposition here shown in red, orange, and yellow. And what we wanted to do, we wanted to target this part of the brain and show that we can safely and reversibly open the blood-brain barrier. We didn't deliver a therapeutic. We didn't even look at efficacy. It was just safety, that we can reversibly do it. And that's exactly what we showed. Here you can see preoperatively the patient's MRI scan. When we open the blood-brain barrier, you can see this rectangular area of contrast that goes away the next day. So this was really the first demonstration that you can reversibly open the blood-brain barrier and that it goes away in patients who are amyloid positive. Now, why is that important? Well, amyloid not only is a risk for Alzheimer's disease, it's the largest risk for bleeding in the brain, for hemorrhage in the brain. And we're able to open the blood-brain barrier directly in amyloid regions and do that reversibly and do that safely. This is the first step towards potentially opening the BBB and delivering a therapeutic to the brain. And this is just all the amyloid scans of all the patients that we treated. This is what it looks like in 3 dimensions. And when you do MRI, you can also do very specific sequences that look for blood. And we were excited to investigate and actually show that not only can we open the blood-brain barrier reversibly, in that same spot, we did not see any bleeding. So T2 star weighted images are specific for blood, and we did not see any bleeding in that area. So we're able to only open the BBB without causing bleeding. Another area that we're quite interested in is ALS. We have a very strong ALS group here at Sunnybrook, and there's a dearth of treatments for this devastating condition. And again, as a proof of concept, we wanted to show that we can open the blood-brain barrier in the motor part of the the arm or leg area of the motor cortex without causing any side effects. And that's exactly what we showed in this publication. We used fMRI to identify the part of the brain where the arm area lives, and that's the area that we opened with the blood-brain barrier. The final indication is glioblastoma, which is a kind of brain cancer. It's the most common, most malignant and aggressive kind of brain cancer. It's one where the life expectancy is really measured in months rather than years. And no real appreciable difference has been made in the last few decades in life expectancy. So anything that could be done to enhance the delivery of chemotherapy for this disease would be a win for the field. So we're really interested in opening up the blood-brain barrier. So this is, for example, a patient that with a right-sided temporal resected, so operated on brain tumor, leaving behind this resected rim. And we're opening up the blood-brain barrier along that resected rim, because when this tumor comes back, 98% of the time it comes back within a centimeter of what you resected. So we want to enhance the delivery of chemotherapy to that part of the brain. So just to conclude again, I want to go over the basic principles. And really, these are the take-home points. And the idea that, again, brain circuits govern voluntary and involuntary human behavior, as we've seen. So whether we're talking about eye movements, whether we're talking about regular getting around the world, or our thoughts related to mood and decision-making, these are circuits in the brain. And that these circuits are not just white matter tracts, they are nodes that are connected mono and polysynaptically. And that dysfunction in those nodes will lead to general circuit-wide dysfunction that manifests as what we call symptoms of brain-based disorders. All of our treatments, whether opening the blood-brain barrier, is making a lesion invasively or non-invasively, are used to restore activity in those circuits. And this continues to have significant implications for how we understand these disorders. So that's where we are now. Where are we going in the next 5 or 10 or 20 years? What we're going to see is more widespread use of neuromodulation for sure for diseases of brain circuitry. There's going to be significant emphasis on less and less invasive things. There's going to be an expansion and refining of current indications for something like Parkinson's disease and tremor. We're going to develop new indications, just like you saw with focused ultrasound. So neuromodulation is one of the rare growth industries. So you're seeing more and more patients being treated, more and more indications. And these are opportunities for individualization of care. So when we see something less complex as depression or anorexia or Parkinson's, we see that complexity as an opportunity, as a way to potentially tailor the treatments to the specific symptoms that are bothering patients. So we've come a very long way from the 4 transducers in the 50s to the 1,000 transducers of today. And I always conclude with this slide, which is that as promising as all of these technologies are, there's always going to be a cycle of interest in them. So as with everything in DBS or focused ultrasound, however exciting they may be, they often go along this kind of trajectory. There's a trigger, and there's a rapid expansion of use of that technology for many different indications. And then it reaches a kind of peak of inflated expectations. And following that, there's a contraction of interest. And that we're seeing that now in the DBS for depression literature, where I showed you there was a recent negative randomized controlled trial. And that leads to a lot of nihilism and disillusionment in the field. But inevitably, that leads to a kind of what we call slope of enlightenment, where we sort of, get back to square one and sort of figure out, well, why didn't this technology work? How can we optimize it? How can we design trials to really answer the questions as best as possible? And then hopefully what will happen is fitting in that technology into where it belongs in the treatment algorithm. So with that, I work with a tremendous team at Sunnybrook, really, really fortunate and lucky to have the students, working with us, and a tremendous group of investigators with whom I'm privileged to work. And yeah, I'm happy to answer any questions. Thank you for your attention.
All right, folks. I know that there were some questions online, and you had some virtual claps going there. It's awesome how students are figuring that out. Awesome. If you feel comfortable turning on your microphones and or webcam, that's up to you. And asking your questions, please feel free.
Can I start, or does somebody else want to go first?
Oh yeah, I actually do have a question as well.
Okay. Why
Yeah,
don't you
so
go first, Yi?
thank you so much. So Dr. Leslie, in terms of the uh, blood-brain barrier disruption, I know that for AD, there are some studies that show that a significant amount of immune cells enter the brain and leads to neuroinflammation and then causing cognitive impairment. So would having blood-brain barrier disruption actually cause a greater impairment in AD, or is the ability to provide pathway for drugs to enter the blood-brain barrier more beneficial?
It's a great question. Really gets at sort of the risk-benefit ratios in the field. So there is some preclinical evidence to suggest that opening the blood-brain barrier can result in increased inflammation in that part of the brain. Now, what we believe is some of the preclinical models that have shown that probably we're using microbubble dosages that were too high, that certainly we don't use in human population. So it may be related to the extent that the blood-brain barrier is open and maybe some damage being caused. Now, it may be that local inflammation may be necessary. It may be that local inflammation may be necessary for clearance of amyloid, for example, or clearance of tau. And there is some evidence to suggest that microglial activation may be necessary in the context of AD in order to clear some of the amyloid there in the brain. So I think you're absolutely right. It's all about a risk benefit. I think what we're finding is that a more sort of refined, lower threshold for inflammation is probably important to do. We're also measuring peripheral biomarkers of inflammation related to damage of astrocytes and other kinds of cells. All of those things are part and parcel with doing these early phase trials to figure out the safety profile.
Okay, I see. So it's just finding that window, that narrow window of benefit.
Yeah.
Okay, thank you so much.
Yeah.
I had a question, if that's okay.
Yeah, of course.
So I was wondering if there's anything published, or if you yourself know what the neurological mechanisms are for deep brain stimulation that stimulating that part of the brain leads to inhibition,
Yeah.
and why that's the case. Like, do you know the mechanism?
Excellent. No, it's an excellent question. For years, the mantra where DBS researchers have been, we don't know how DBS works. We don't know really what the effects are. Now, there have been some computational modeling in the DBS field to suggest that the effect of DBS may be different if we're talking about axons versus cell bodies. So it may be that it drives activities along the axons and inhibits activity at the cell bodies. So it may be both a combination of sort of an excitatory or inhibitory effect. Obviously, it will also depend on what the downstream effects are. So if you're, locally, if there's local neurotransmitter release, that's GABA, you're going to have sort of a local inhibitory effect, but at the same time, you're stimulating release of GABA. So I think that a lot of it will depend on sort of what target in the brain you're accessing. Are you accessing white matter pathways? In the example, for example, the subgenual cingulate, which is not a gray matter target, or are you targeting, a nucleus in the thalamus where the effect is most likely inhibitory? So a lot depends on the tissue, on the vascularity, on the neurochemical milieu, and also on what part of the neuron you're stimulating.
I see. Thank you.
Hi, Dr. Lipsman.
Hi.
I have a question. I was wondering if there were any applications for the focused ultrasound on contrast agents where it doesn't open the blood-brain barrier, and if that might have potential applications for things such as clearing plaques in ischemic stroke.
Yeah, no, it's a great question too. So we use contrast agents in two ways. One, to actually open the BBB, and that's the microbubble containing contrast agent, which is used for cardiac imaging usually, and we use it now off-label. And we also use contrast gadolinium to demonstrate that the BBB is open. We're strongly interested in in other agents that could potentially visualize what it is that we're doing, whether it's using amyloid tracers or using tau tracers or using other means to visualize pathology in the brain. We're also interested in tagging therapeutics with radioligands to actually visualize they're entering into the brain. We're doing that in the breast cancer in a trial where we're treating and we're delivering therapies to the brain in breast cancer. We're tagging chemotherapy with a radioligand, and we're actually able to visualize it in the brain. So different uses of ultrasound, of contrast agents.
Thanks.
I had a question about patients who refuse surgery.
Yeah.
So what are usually their main concerns for refusing surgery as well, or like reasons why they refuse surgery if they are eligible patients for the treatment?
Yeah. No, it's, we struggle with that a little bit because sometimes, you may have patients that may benefit from something like Parkinson's and they don't want surgery. So it's usually just a concern about the actual operation and the risk. So the risk of bleeding, the risk of infection and brain swelling and neurologic compromise, those risks are not high. They're less than 5%, but some patients don't want to take that on. With DBS, some patients don't want an implant either. So they don't want a permanent implant in their body that requires constant upkeep. So that's the other thing that sort of turns a lot of patients off.
Thank you.
Sure.
Hi, doctor. I had a question.
Yeah.
So, I was wondering, does DBS relate to or maybe like greatly affect the either local or more global excitatory inhibitory balance in the brain?
It probably depends on, similar to what I was saying, it probably depends on the target in the brain you're targeting. So it may not do it in a global way, but it'll certainly be doing it in a circuit specific way. So for example, if you're targeting the subgenual cingulate, where there's a lot of serotonin maybe in that area, you may be seeing changes in serotonin levels elsewhere in the brain. If you're targeting dopaminergic areas, you may be seeing, excitatory effects in some of the direct and indirect pathways. So it depends a lot on which area of the brain you're targeting and what the effect is locally at that area.
Right. And so I guess, is it ever the intention, or has DBS been used in a way that it tries to target or alter the more global EI balance?
It depends a lot. I'm not sure if it globally, but it depends a lot on also, something I didn't mention is that there are a lot of parameters that you can certainly play with deep brain stimulation, specifically the frequency, the amplitude, and the pulse width. So all of those are different settings that you can play with in order to change the excitatory and inhibitory impact of stimulation locally. So it probably doesn't lead to a global increase in excitation or inhibition, but certainly circuit specific levels, it certainly will.
Okay, I see. Thank you.
So Ishan, could I ask, was that question related to ALS or was that related to something different? Like, just curious.
Yeah, I guess I've been reading a little bit about EI balances, and it seems like an EI imbalance underlies so many different conditions and diseases. So I was wondering if, like almost to the point where I thought it could be some kind of syndrome. So I was wondering if DBS could have a more generalized or widespread use like that.
I was just curious, mainly because we've been talking a little bit about like the dying forward and dying back hypotheses. So pure curiosity on my part. Thanks, Ishan.
Yeah, of course.
Are there any other questions? Yeah, Silva. Yeah.
So I have a question about the MR-guided focused ultrasound in treating essential tremor. So we mentioned that are we at one time only treating one side, or is it only possible to treat one side using this procedure?
It is possible to treat more than one, but we are at this stage only treating one side because the risks of treating at the same time both sides are too high. That said, we do have a trial currently ongoing to treat bilateral, but in a staged fashion, where we would treat one side, and if patients are well and they're doing okay, they'd come back the following year to have the other side treated.
Okay, I see.
Just a quick question. I was wondering if using DBS had any limitations on what patients could do with their daily lives, such as like intense sport activities.
Yeah, I mean, patients have gone on to do lots of activities, skydiving and sports and things like that. Obviously, the party line from our perspective is always going to be not to do those things because of worries and concerns about damaging the device. So I think that it hasn't really led to a lot of limitations that patients find. Now, of course, patients that often get this are often, for Parkinson's, are often older, et cetera. So they're not really going to be engaged in that stuff. However, you know, if younger patients are doing it, they have not found it to be a significant limitation.
Thanks.
I think somebody just asked something. It seems so far that ultrasound may be used in patients that experience symptoms related to AD or PD. Is it possible to use these techniques before major symptoms such as tremor, changes in speech? So that's a great question, and it has to do with sort of where ultrasound ultimately is used in the treatment algorithm. So in both of those, in Alzheimer's disease, it's highly experimental at this stage, really in phase 1, phase 2. So we don't yet know whether it works. We're just really investigating safety. But the goal ultimately, if it does work, and even if it doesn't in this trial, to trial it in another population, is to try earlier. Because if you can show that something is relatively safe, then using it early does make sense. And it makes sense to do it before symptoms develop. So that there's certainly interest in that. And then there's a question about DBS versus top-down or bottom-up. You know, this to me is a critical question because I think that what we're doing with DBS, and even with ultrasound, but with DBS, we're targeting, I think, autonomic centers and key centers. I think it is a bottom-up approach, maybe supports both. However, obviously, these parts of the brain, they participate in things like perceptual processing and limbic effects. But so it really, this is almost a philosophical, you know, phenomenological, existential question, you know, because, you know, the way that I think about it, if you think of Freud, you may have heard Sigmund Freud talk about how conscious awareness is the 10% above if you look at, if everything is an iceberg, you know, conscious awareness is everything you see above the water, but there's 90% happening beneath, which is our unconscious processing. The way that I think of DBS is you're tackling an element of the 90% below, and you're hoping that it manifests as a change in the 10% above. So I do think that it is a bottom-up kind of process, and that it is up to the clinician, psychiatrist, et cetera, to make sense of that. So I think this really gets at a key question. And then in anorexia, would these treatments be able to be applied to other feeding? So short answer is yes. And I think that, you know, the way that we define whether something may be eligible or condition should be explored is it has to do with the balance of risk and benefit. And usually the patients who are the sickest with eating disorders are going to be the AN versus the BN versus the bulimia patients. And that's not to say that the bulimia patients are not suffering or that they don't have a poor quality of life. Obviously they do. It's just the most immediate threat to life is going to come from patients who have the traditional sort of anorexia restricting subtype and the binge purge subtype. And those are the ones for whom the limbic dysfunction seems to be most apparent and most obstacles to getting better. So that's why that has stayed in that population.
All right, so some great questions, and thank you so much for spending the time sharing your expertise and your knowledge with the class. I'm going to actually stop recording here at this stage. I think I like what we've been doing recently, which is